Hello, everyone, and good morning. Thank you for joining us for this press briefing of the Africa CDC, where Dr. John regularly briefs the media on issues around the COVID-19 pandemic in Africa. Today, he's also joined by Dr. Merawi, and he will be talking to us about the Ebola outbreaks that are happening in the DRC and in Guinea-Conakry. Dr. John will also take time to update us on the situation of the vaccine acquisition as well as the distribution in Africa. So that is our lineup for today. But before we continue, you can continue to get in touch with us when we get to the question and answer session using our usual WhatsApp number, also using the Zoom platform, both the live as well as the question and answer section on that particular platform. So my name is Wayne Musabayana. I'm head of communication at the African Union, and it is our pleasure to bring you this press briefing every Thursday at 11 a.m. East African time. Right now, let me welcome Dr. John, who is the director of the Africa Centers for Disease Control and Prevention, for his usual Thursday morning briefing on the COVID-19 situation. Dr. John, you have the floor.
Thank you, Wayne, and a very good morning to everyone and the colleagues that are on this platform, the media, the journalists, and others who have joined. As usual, we will start with the epidemiological update and then discuss what Africa CDC is doing, and we'll end up this first part on COVID-19 with the vaccine update, which I know it is of great interest to many. So let me start with the epidemiological update. As of 9 a.m. East African time today, the world has, as we know, that the numbers continue to increase, but I'll just focus in Africa, that we have reported over 3.8 million COVID-19 cases. That accounts for about 3.5% of the total global number. Around 89%, very good recovery. That is about 3.4 million people that were infected have recovered in Africa. The total deaths today stand at about 102,000, and to be very specific, 102,470 cases of individuals who have died. Unfortunately, our case fatality rate is now at around 2.7%, slightly up from 2.6% the previous week. Now, if you look at the continent and we look at the number of countries that are accounting for about 66% of the caseloads, they include South Africa, representing 39% of the overall caseloads on the continent, Morocco 13%, Tunisia 6%, Egypt 5%, and Ethiopia 4%. So let me just dwell a little bit on the case fatality ratio. And the global, just to put it in context, the global case fatality ratio is 2.2%. However, if you look at our continent, 38% of our member states, representing 21 countries, are reporting a case fatality ratio of above 2.2%. And I will not list them all because, again, 21 countries in that category. So that suggests that even though our trends are coming down, as I'll discuss later, the number of people dying, of course, has increased and actually exceeded the global case fatality ratio. So just a word on the variants. 9 member states have now reported the B117 variant, and they include DRC, Gabon, Gambia, Ghana, Morocco, Nigeria, Senegal, and South Africa. Again, I will leave it at the B11 variant, And as Africa CDC, we take an exception in labeling variants to any country. 10 member states have reported the variant, the B1351, and they include the Botswana, Comoros, DRC, Gambia, Ghana, Kenya, Malawi, Mozambique, South Africa, and Zambia. In terms of the changes, if we compare the week last week, which is the epidemiological week 6, and the current week, which is the epidemiological week 7, we observe the following trends in terms of new cases. Overall, 74,000 new cases have been reported across the continent. The highest proportion of these new cases, representing 39%, are from Southern Africa, 22% from Northern Africa, 19% from West Africa, 15% from East Africa, and 5% from Central Africa. The following 5 countries are reported the highest number of new cases over this last week. South Africa with 11,000 cases, Nigeria 5,800 cases, Ethiopia 5,700 cases, Tunisia, Mozambique 5,300 cases. If you now look at the number of deaths, that is over the last week, we've recorded a total of 2,786 new deaths across the continent. And this represents a 19% decrease from the previous week. If we now look at the last 4 weeks, that is the week between January 25th and February 21st, we observe an overall average decrease across the continent of 19%. And these decreases translate in the regions, the 5 regions, as follows: 27% decrease in Southern Africa, 17% decrease in Northern Africa, 9% decrease in Western Africa. However, a 6% increase in Eastern Africa and 2% increase in Central Africa. If we now look at our most populous countries across the continent, South Africa has observed an average of 36% decrease, Nigeria 15% average decrease, Egypt 4% average decrease. However, Ethiopia has now observed about 25% average increase, Kenya 14% average increase, and DRC no change. In terms of deaths, over the last 4 weeks, we've observed 18% average decrease in new deaths reported in the continent each week. We now transition to the testing. As a continent, we have the continent has reported an accumulated number of tests as follows: 34 million tests conducted overall, with a case fatality rate of 11.3%. Over the last week, there was an increase of 12.6% compared to the last week, representing about 915,000 tests reported. 1,000 sequences have been uploaded into the international portal to monitor the circulation of the new variants. In terms of capacity building for Africa CDC, we continue to work with countries to support them on safe vaccination administration in the context of COVID-19. And it will be very important to note that training for COVID-19 vaccination by Africa CDC will be starting very, very soon. And I'll come back to that very shortly. So let me now segue on vaccines and vaccination. You all recall that a few weeks ago, President Ramaphosa, as the chair of the African Union at that time, announced that AVAC, that is the African Vaccine Acquisition Task Team, had secured about 270 million doses of vaccines. It is my pleasure to let you know that all these doses have been allocated to countries, which means countries have now stepped up, and we needed to have all of those countries make the allocations, and then the Afrexim Bank will work with them to finalize the contracts, and then the supplies will begin. So that is already a very good progress. And the breakdown, the detailed breakdown, can be made available to you next week. The Africa CDC's regulatory task force has now approved the emergency use listing of 2 versions of the AstraZeneca vaccine, that is the ones produced in South Korea and the Serum Institute in India. As I indicated earlier, Africa CDC, in partnership with the HOPE project, will start training on vaccination of 20 countries this week. And then next week, we'll continue to do that both starting in Ethiopia and then in South Africa in the subsequent week. The African Union has endorsed the proposal of the World Trade Organization that could allow countries to choose not to apply or enforce certain types of intellectual property on COVID-19 medical tools during the pandemic. Let me just also announce the good news that the European Union last week announced $120 million contribution to our Africa Vaccine Delivery Alliance to support vaccination rollout. That is the systems that will be required for vaccination, and we are truly grateful for that contribution. You all heard yesterday that and watched on the news that Ghana has received its first consignment of the vaccines, COVID-19 vaccines, and these are from the AstraZeneca shipment from COVAX, and it represents the first nation to have received these vaccines from COVAX. So we are very excited. I mean, about 600,000 doses of vaccines were shipped to Ghana. So that will at least get us started in Ghana, and then we'll keep, hopefully in the coming days, more deliveries will be done. Last week, I did mention that from the AU side, the AVAC, the African Vaccine Acquisition Task Team, will start the distribution, and we are very, very working hard to make sure that, as I indicated, that this week, those distributions really start. This week meaning either they start today or tomorrow. And if there are any delays, we really don't project that they will go past the weekend or Sunday. Delays in logistics of moving it around. So the packaging all done, the distribution mapping is done. It's a question of pushing out the logistics there. So we will formally, hopefully before Thursday, we'll issue a press statement to expand on that. Let me, before we open it up or give it back to Wayne, let Dr. Mirawi give you an overview of what the Ebola situation is. As you recall, we are fighting 2 Ebola outbreaks, one in the DRC. Dr. Mirawi.
Thank you, Director. Good morning, colleagues. I will just give you an overview of what's happening about Ebola outbreak in Africa. Overall, in 2 countries, they are Congo and Guinea. A total of 17 Ebola cases have been reported, with a total of 9 deaths, with case fatality rate of 53%. These outbreaks are not linked, for your information. In general, when we go to DRC, 8 confirmed cases and 4 deaths with case fatality rate of 50% have been reported into health zones in North Kivu. Bena health zone, 5 cases, 4 deaths. Katwa health zone, 2 cases with no deaths. And Musenene health zone is 1 new case reported very recently. So in general, in DR Congo, About 6 contacts have been listed. 70% of them, 746 of them, are under 659 eligible contacts have been vaccinated. The DRC Minister of Public Health is working with partners, including Africa CDC, to establish coordination and response mechanism that will help to contain the outbreak as quickly as possible within the epicenter. In the Republic of Congo, 9 cases, 5 confirmed, 4 probable cases were reported with 5 deaths, with case fatality rate of 56% in 2 regions. It should be noted that last week we reported 6 deaths. The one suspected death was returned to be negative lab result. So we have now 5 deaths. 2 cases have recovered and has been discharged from treatment center, one in Conakry and one in Zorokore. To break down by health zones, Conakry reported 1 case, no deaths, and this case has already recovered. In Zorokore, 8 cases reported, 5 deaths, 1 already recovered and discharged. In general, the response in Guinea is, as of today, 382 contacts have been registered, of which 106 completed their follow-up and 276 are currently under follow-up. Over 11,300 vaccine doses have been delivered to the Republic of Guinea, and the vaccination officially began on Tuesday, 23rd February. As of today, 51 eligible individuals have been vaccinated, 11 are in Conakry and 40 in Zorokore. Screening is in place at ports of entry, and investigation for the origin of the outbreak is ongoing with a review of medical records, registration books, and so on. So investigation is still going on to set out the origin of the outbreak. The Africa CDC supported this disease outbreak response. One, we established or activated our emergency operations center to manage or support, coordinate both disease outbreaks in DR Congo and Guinea. Our field team, advanced team in Guinea, is working closely with different partners and with the Ministry of Health to develop the National Emergency Response Support Plan. And also they identified the needs and gaps currently, and we here at HQ, from the preliminary report from the field team, developed our emergency response support plan for the whole region. So saying that as Africa CDC, we put forward as a guidance, at this time, the Africa CDC recommended the following to member states to enhance their cross-border surveillance across the region, map population movement to identify all potential crossing points where there is a risk of disease spread, set up a screening posts and conduct health screening for travelers with signs, symptoms of EVD and Ebola and so on. Implement public health measures at border screening points, including temperature monitoring, infection prevention and control, and share information. Information is really vital to curb this outbreak, and we need across borders. We recommend member states to share information across the region. Thank you. Back to you, Director.
So Wayne, thank you, and over to you.
Thank you very much, Doctors John and Merawi, for those really comprehensive briefings on the 2 epidemics that we're fighting, the COVID-19 and the Ebola outbreak. Now we are at the time when we take the questions from the media, and the first one is coming from Deborah Matabu. And Deborah says, I'm a reporter at the Sunday Mail newspaper, a weekly paper in Zimbabwe. And the question that she has, she says, how many African countries have started COVID-19 vaccinations, and which vaccines are they using?
So thank you for that question. First of all, let's celebrate the good news yesterday about the vaccines arriving Ghana. from the COVAX facility. And the importance of that is that I've stated many times that COVAX represents a symbol of cooperation and global solidarity that we have always talked about. I think that has to be recognized. This in challenging times, like what we are dealing with, this pandemic now for the past close to 1 year and now 2 months almost, every little step in the right direction should be celebrated. So we really are happy with that. So with that said, which countries have started vaccination? Let me start from the south and move upward slowly. A journey of 1,000 miles begins with one step. And that is that once the few steps that we are doing will hopefully add up in this pandemic. And we hope that in the course of this journey, we accelerate this so that we can be ahead of the pandemic. So South Africa has started vaccinations with Johnson & Johnson. You saw President Ramaphosa take the vaccine live. And then when you move up to West Africa, we now know that Senegal started vaccinating with the vaccines from China. Ghana received their vaccines yesterday, and hopefully they should start vaccination today. And then you move up north, you get Morocco and Egypt that have started vaccinating mainly with the vaccines from China. And then we also know, if you go eastward, that Seychelles had been vaccinating with the vaccine from China. I think those are the countries that are known. Now, Guinea, earlier on, we know that we did some very early vaccinations with about 60 people with a Russian vaccine. We have not heard more from that vaccination program. And it is safe to leave it at that. We, Africa CDC, will be establishing a comprehensive mapping of who is vaccinating where and with which vaccine, so that you can each time go onto their website, click there and see how the continent is flooding. But again, as I said, let's celebrate these early steps. The vaccine situation scenario, we've all discussed it on this platform over and over, how challenging it is, the efforts that we are all doing. And I'm very pleased, personally pleased, to see that some of the movement have started.
All right, thank you. We go now to Eswatini, and we are joined by Bonisile Makubu from the Times of Eswatini. And she says, last week, His Majesty King Mswati III told the nation that he survived COVID-19 after using remdesivir, which he got from Taiwan. He then commissioned government to secure remdesivir for all Swazis to treat COVID-19. What is the Africa CDC's advice to Eswatini, as this drug has not yet been approved by the WHO for COVID-19?
So remdesivir has, as you recall, was one of those drugs very early on that was available for treatment of especially severe cases of COVID-19. And it went through the trial, the Solidarity trial, and we now know, and that is very old news already, that it didn't really show any significant improvement when you compare those who took the drug and those who did not take the drug in a control trial. It didn't show any effect there. So that is all I can say with respect to that we should always allow science to drive our response to this pandemic. We shall only win if we use science-driven approaches that are backed with sufficient data to make informed decisions how to fight this pandemic. Anecdotal experiences will not help us. It will only just get us confused. I think that is what I will say at this point, speaking very broadly. I've not seen the situation in Eswatini. That is, I don't know the details of what you are referring to. So my comments should be interpreted very broadly, that we are giving general recommendations and guidance to our continent.
Thank you very much, Dr. John. We have Girum Chala, who has raised his hand online, and Girum is with CGTN, I believe. Good morning, Girum.
Good morning.
Morning. Please go ahead with your question.
Good morning, Madam Wayne and Dr. John. I would like to ask a very important question. I've been here in the United States for another assignment, and the situation of not wanting to be vaccinated across this country can be visibly seen. But the same inclination of Africans, like in Addis and other places, of developing some kind of phobia or mistrust towards the vaccinations, people saying we're not going to be vaccinated, is growing by the day. Maybe, I don't know if you have noticed it so much. So my question is, what is really the African Centers for Disease Control and Prevention going to do about it, with perhaps in collaboration with member states? And the other thing is, you said 60% vaccination is going to result in the most important herd immunity. And this attitude, isn't it a worry that it could affect your future plan?
So thank you, Guillaume, for those two very important questions. First of all, with respect to the first question on the acceptability of vaccines for the continent, and what I'm going to say aligns with my previous comments on that we should use evidence and data to drive our struggle and fight against COVID-19. We, as Africa CDC, took a very early leadership approach to generate evidence and science several months ago, and where we commissioned a large-scale study that included 15,000 participants from across 15 countries in Africa, 15,000, 15 countries. You can imagine 1,000 per country, using very proven scientific methods, including in partnership with the London School of Hygiene and Tropical Medicine. So what was the outcome of that survey? The key question, the central question there was, that we posed to our continent was, if a vaccine was available today against COVID, and that was safe, would you take it? So that is the central question. I think the good news is that about 60 to 70% of the population said they would take the vaccine. So the lower range was 60%, the upper range was about 91%, if I recall. And that 91%, I'm pleased to state, that was from Ethiopia. Okay, that is so it gave us a range that was comfortable, because if you and I recall what we are seeing in some Western countries, acceptance rates are as low as 40%. So this is very encouraging. What does this mean? This suggests to me and to us, Africa CDC, that we have to now design programs that will target countries that were on the lower end of that acceptance rate. That is, countries that reported about 60 to 70%. So you have to flip it now and look at it and say, well, why did the 40% or 30% of that population in that country were hesitant? It is absolutely normal that when people are faced with a situation and a scenario where there's fear, there's insecurity, they tend to resist change. So it is up to us in public health, together with the media like you and the civil society and the community, to work together in the spirit of the wholeness of society to address the issues that will enable us overcome this whole issue of vaccine hesitancy. It is there. It is not new. It has been there before COVID-19. It has further been complicated by social media, those messages that we receive through different fora. But we need to fight that, because if we do not vaccinate up to that level, there's at least 60% of our continent. Trust me, we will be known as the continent of COVID going forward. We truly don't want to see headline news that says COVID-19 in Africa from a pandemic to an endemic disease. That would be extremely complicated for us as a continent, given what we are already dealing with in terms of HIV, TB, malaria, non-communicable diseases, and childhood immunizations. COVID-19 is extremely disruptive to our economies, is extremely disruptive to our health systems, is extremely disruptive to our health security. So we cannot even do that. So the 60% that we stated as a target for the continent should be seen as a minimum that we should be striving to achieve 60%. Again, just to conclude on that, all efforts to get the community rally and the vaccines that will be pronounced on positively or approved by the Africa CDC and or WHO should be really be a common call for action by all of us.
Thank you very much, John, for that. We move on to Reuters, and we are joined by Alex Winning. And Alex says, I have two questions about the AU's vaccine plan. The first question, have formal deals been signed yet with Johnson & Johnson, with Pfizer, and with the Serum Institute for the 270 million doses that you said had been allocated, or are they still being negotiated? So this is one question. The second question, are you on course to start delivering vaccine doses via the AU plan in March as planned? So those are the two questions from Alex Winning of Reuters.
No, good questions. I mean, for the 270 million doses there, let me just again explain this hopefully very clearly. First, you have to secure, so we put the 270 million doses on the platform. And then second, we reach out to the countries and say, look, member states, here you are. We assign you a code, go to the amsp.africa and then put in your orders. You cannot go ahead and sign contracts without those orders coming in, so that it takes time for countries to work with us, because so many countries have come to us and said, well, we have challenges going through the platform. We are not familiar with this platform. So we've provided technical assistance to countries to get those their orders in. So now that, as we say, the orders are in, with the Afri-Exim Bank, which is the main underwriter, they will now take those and then move forward with the signing of the contracts there. So in other words, you couldn't sign a contract without knowing who is going to buy the vaccine. Now that we've closed that deal, the contract signing and processes are ongoing actively. I would describe as ongoing. I would just like to say that I have never been part of any group that works every day. I mean, from 8 o'clock to about 10 o'clock at night, working on just how do we deliver vaccines on the continent. That is the task force that President Ramaphosa puts in there, and is really a commendable exercise that you are looking at all facets of how do we move this forward quickly? How do we bring in the lawyers to sign up the deals, and every day from 8 p.m. to about 10 p.m. at night. Now, with respect to the delivery in March, that is still our target. We're hoping that the March, April timeline, we will be, will hopefully deliver. But just keep in mind that we are projecting to start delivery of the first doses in the coming days, okay? I mean, in the coming days, to about 16 to 20 countries, which I stated earlier. And we will, and these vaccines, those early deliveries will be those vaccines that were secured using the donation from the MTN, the $25 million donation that MTN provided to Harvard. And we have now used that to secure the first distribution, which will be extremely exciting as a proof of concept that this can be done. And it will also enable us to, when the vaccines get in country, to start vaccination and learning from it as to how these vaccines will be appropriately distributed. So I think I'm personally excited that tiny steps are being done. Early results are being recorded in terms of introducing vaccines on the continent.
All right, thank you. We stay with Reuters, and the next question is coming from Omar Mohammed. And Omar says, A few weeks ago, Dr. John, you said that you had reached out to China and Russia to get access to their data on their vaccines. Did you get this data? And will you be approving their emergency use for African countries?
Yes, we did reach out to those countries, as I stated, and the Russian, the Gamaleya group that produced the Sputnik 5 have submitted their full dossiers. And I'm pleased to state that in the coming days, I think hopefully next week, the panel will come together and then start discussing. We're having 2 levels of discussions. We will meet with the manufacturer to explain to them how the process will work. And then secondly, the manufacturers will retreat, and then the expert committee within the task force will now review their dossiers and then make a pronouncement on those. As indicated earlier, we will also today or tomorrow be issuing a communique that says that we are approving the AstraZeneca vaccine, which were already approved by WHO, again, based on our guidance. Remember that we as the Africa Union, Africa CDC, the AU, NEPAD, and WHO have issued guidance, which you can read on our website, on how we shall be approaching vaccines approval on the continent. So the AstraZeneca vaccine, and that will be issuing a statement today or tomorrow, falls under scenario 1, which is that a vaccine that has already been approved by WHO, we look at it and we say, look, this is great, don't repeat the wheel, just move forward. Scenario 2 are those vaccines that have been approved by respected regulatory authorities like the FDA in the US or the European Union FDA. We look at that, and then we also, as the African Regulatory Task Force, produce an opinion on that. And lastly are those vaccines like the ones that you just cited, i.e. the Russian vaccine and the Chinese vaccines that would have not gone through any of those, and we will use our own task force to review that. So you are covered as a continent with respect to, if countries go through our own processes, then you are covered in terms of the regulatory processes there. So just to conclude that section, we have not received dossiers yet from our China colleagues. We remain optimistic that they will submit to us their dossiers.
Thank you. Daniel Finan from Radio France International has a couple of questions. So Daniel says, what is your interpretation of the seroprevalence surveys that were carried out in Nigeria that suggest that in some states, like Lagos State, 1 in 5 people have been infected with COVID-19? He then comments that if extrapolated, this suggests that millions of Nigerians are already infected with COVID-19. Then the next question that he then asks the question, what happened to the 400 million doses of vaccines mentioned as offered to AVAT? Are these confirmed? And then finally, he says 26 countries are said to have applied to AVAT to secure vaccines. Which are these countries? So those are questions coming from Daniel Finan of Radio France International.
So very good questions. And we are very pleased to see the first results on the sero surveys coming out from Nigeria. And I would just like to put that in context that last year, you all recall that Africa CDC had commissioned that sero surveys be conducted in several countries, and we are beginning to get early results. We'll aggregate those results, and hopefully in the coming weeks or months, we'll be able to give you, share those results with you. Now, the Nigeria study is one of those very early studies. It's very well designed. Those are household surveys and across some major cities in Nigeria. So what that study suggests to us is what we have been saying before, that the spread of this virus, a virus that moves very quickly and is easily transmitted, that on the continent could be much more than what we had, what the molecular tests are reporting. If you recall this, I just said today that about 3.8 million people have been reported to have been infected on the continent. That is based on the standard, what we call the gold standard, the polymerase chain reaction test, the molecular assays there. The test, what is you heard or read from Nigeria are the serology, which means simply, have I been exposed to the virus? And if the answer is yes, you use an antibody test to detect that. And that is what Nigeria did. And that is what we are going to do. It gives us, it confirms that we're dealing with a virus that spreads very, very quickly. It also confirms that high recovery rate that we keep indicating in this briefing, that we are saying that as a continent, out of the 3.8 million people, about 3.4 have recovered. It also speaks to the epidemiology. Fighting this virus is so challenging. The relative virus, which is the SARS virus that was reported 20 years ago in China, was easy to be defeated because it was only transmitted when people were sick, okay? And so you could actually use your thermometer and test out the temperature of an individual, or if they are coming down with fever, and then isolate them. But this virus deals slowly through people who are symptomatic. So it's not surprising to that many people have been exposed in Nigeria, in a major city like Lagos, and and it will give you the several press that you get in the news yesterday. So I think it aligns what we were speculating all along, that more people have been infected and complacent with this virus, that we have to continue to wear masks, continue to avoid crowded rooms, continue to avoid mass gatherings at all times, and that the community needs to be at the center of this response, because one extra death is one too much for us to accommodate as a continent. We have, as a continent, unfortunately, witnessed about 102,000 deaths. So this is not a joke. If at the end of last year, or last year, in 2019, someone would have said, John, 100,000 Africans are going to die. What would you do? All of us will be all over trying to find ways to make sure that that doesn't happen. So again, we should put those findings in the right context of, this is a dangerous virus, it's spreading very quick, and we have to deny that virus the ability to spread.
Thank you very much, John. Our questions are coming in thick and fast today. But let's move on to Paul Adepoju from The Lancet. And Paul says, do you know why Ghana was the first country to receive vaccines through COVAX? And then secondly, he says, which country or countries will be the first to receive COVID-19 vaccine doses through the African Union? That's from Paul Adepoju, The Lancet.
So for the Ghana scenario, I'm not privileged criteria for choosing Ghana from COVAX, and we, as you can hear from my tone today, I'm in a celebratory mode of saying, bravo, Africa has started receiving vaccines. I think the details of why Ghana, not Nigeria or Cameroon, I will leave that up to COVAX. There will always be a first country. But what I want to leave you with a message that it's a rolling process. It could be possible that today, even in a plane lands in another country without the vaccine, and then I will not really invest my energy with asking whether they should, why that other country received the vaccine. What we should be doing now is to collectively working with the community in Ghana, encouraging them to get out there quickly, especially healthcare workers, and get vaccinated. As Gideon said earlier, there's this hesitancy in the community. Let's work to make sure that those 600,000 doses of vaccines get consumed very, very quickly in Ghana. The question of the AVAC distribution, I think I addressed that earlier on, which I said we are really working hard that between today, tomorrow, or over the weekend, that the distribution starts in about 20 countries. And we'll be happy to send you to distribute the list once we have it. We'll put it up on our website in the spirit of everybody has been sharing that information. But we are very, very close. We're very, very close with the logistics of moving those vaccines out to at least 20 countries, and we'll make sure that you have the list by next week or next week Thursday. We'll read all 20 countries, and again, those will be a rolling process that we'll keep moving them forward as much as possible. I wish that we had a scenario where we could send a plane to go into that warehouse, pick out those vaccines and start distributing it all over 55 member states at the same time. Logistics don't work like that.
All right, thank you. We say good morning now to Addis Getachew, and he is with Anadolu Agency. He says, my question is to Dr. John. What do you make of this much talked about vaccine passport? The issue has been hugely divisive globally, while many countries are still considering implementing it. So his question is, how does that affect us as Africans?
So that is an extremely important question. And we were the first, Africa CDC, to raise our voices and say that could not and should not happen, because that would further increase the inequality divide that we already are experiencing. Now, in future, would that be possible? Our position is clear. Let's focus now in getting vaccinations in a timely fashion to all populations in the world, or everyone in the world that needs a vaccine. Okay, then we can now say at that point that now, in order to prevent residual re-emergence of this virus, we will make sure that anyone who is traveling have to show that they have been vaccinated. Otherwise, it becomes a very divisive issue where we want to be vaccinated. We have money to buy vaccines, but we don't have access to vaccines. At the same time, you're saying, well, you have to prove that you are vaccinated before you travel. So I think that has been our position. We are not against a vaccination passport, but we are saying that let everybody have access to vaccines. We get ourselves vaccinated, then we can make sure that way the playing field is level, and then we can now use a level playing field to move forward. But for now, it will be extremely unfortunate if such measures were to be imposed, because they will further exacerbate the inequality gaps that exist already across the world.
Indeed, thank you for that. Sarah Jerving with Devex has a question for Dr. Merawi. Can you talk a bit about how the Ebola virus can re-emerge in survivors of the disease and how that can spread it to other people? What is the time frame on how long this is possible? And do you have thoughts on whether this has already happened in the DRC and in Guinea?
Thank you very much for that question. Yes, if you remember in our last weeks, the first case in DR Congo was a house of a survivor. And she was, they have very close contact and so on. And the virus is very tricky, and there is a possibility that this, when we sequence, the sequence revealed that there is a potential that she acquired from another survivor, or she has her own virus, maybe previously, that re-emerged back. And the other one is she may also acquire from her husband. That was the scenario that was revealed from the sequence last week. So with regard to the, this virus can hide in immune protected areas like the gonads and so on. So there is a potential that they can be shared from there for quite a prolonged period of time, more than 8 months or so, 9 months, sometimes even more than a year. They can shed, the patients can shed from that, and that can be evidence of such an outbreak. So for dealing that, there is a protocol for post-outbreak management and follow-up of these cases. We usually continue surveillance in the region, and that has been done in DR Congo continuously. And survivors were monitored for their semen and so on, with regular check of their, with laboratory, sequencing and so on. So this is okay. The other source maybe from the another jump from the animal or from the environment. That is also another source of the outbreak. So with this virus, we deal with different protocols: pre-outbreak, during outbreak, and post-outbreak. We usually handle with different protocols, knowing that the virus may emerge either from the survivor or from the host, from the animal, like the previous one. The first was the second outbreaks. If I miss the question, sorry, if I can get the second question also.
All right, I'll come back to you, Dr. Marawi, because I had moved on to a different platform because we're sourcing questions from different platforms. So I'll come back to you on that. But now I have a question from Vinicius Assis, and Vinicius is from Brazil. And the question is, Tanzania's president admits that the country has COVID-19 and that this is a problem. So the question to Dr. John is, what is your opinion about this?
So it's very much welcome news. And on this platform, you all recall that we have been very persistent and insistent on calling on Tanzania to work with us, Africa CDC, which is their public health agency, to make sure that we tackle this disease collectively, because we recognize that COVID-19 would not be eliminated on the continent of Africa, except it's eliminated everywhere. So we are very, very pleased to see that recognition by the president of Tanzania. We have also stated that Tanzania is one of the 6 most populous countries on the continent. And public health is about pathogen, the population, the policy, and the politics. And if you miss any of those, and if any of those are misaligned, we are in trouble. And I'm extremely encouraged that the president has taken on a positive step in the right direction to recognize this, and we will be working with them actively. We just continue to encourage them to engage with us, share data, so that we can understand what is going on more in depth. Especially given that a gap has been created since last year in terms of reporting, and then we can now develop a strategy, appropriate public health strategies to engage with them. The founding principles, or one of the very important founding principles of the African Union, which was born out of the Organization of African Unity, the OAU, was that of unity. And I think if there's any time that unity has ever been important in our contemporary history of the continent, it is now. It is the unity of purpose to fight this pandemic, and so that we get out of it together. We have to get out of it together, or we'll be doomed forever. So really, I encourage with what we are seeing from Tanzania.
All right. The next question is very much related to that one, but perhaps you might have an extra comment to make on it. And this is coming from Peter Mwai from the BBC. And Peter says, we have had concerns in Tanzania that the coronavirus could be spreading there. Recently, we had the death of the vice president of Zanzibar, and the country hasn't been reporting any data since May last year. At Africa CDC, do you have any information on what is happening in that country? And what can you say about that? I know you've spoken to this in the last question, but I just wonder if you have a few specifics on what is happening in the country of Tanzania.
No, thank you, Peter. First of all, as I stated last week, our sincere condolence to the Vice President of Zanzibar. And as stated earlier during this conversation, that any one death in Africa is one too much to accommodate. And that we should always avoid a scenario, a situation where we begin to normalize deaths because our deaths are fewer than some other countries or other parts of the world. No, this is real. This is loved ones, fathers, mothers, uncles, children, and others. So we should really always put a face to that. I mean, so we are sincere condolence to the family of the Vice President. With respect to the how much we know, our latest or the last time we had numbers from Tanzania was last year, as you stated, and it's frozen at 509 cases reported. Now, we don't know more about that because we need accurate information that we can share with you from Tanzania, information that is vetted through the government of Tanzania, so that when we report it, we're standing on, again, the whole concept of data evidence that are informing our pandemic response. So we do not, but we interpret what the signals that have come out from Tanzania as very good signals that will now hopefully allow us to re-engage with the public health authorities of that country to get more information and data that we can share with you all. And they can join the club of the remaining 54 member states that are reporting their data on a daily basis, and at times twice a day. So Peter, I'm sorry I cannot be more explicit on that for you.
All right, thank you. We move on to Abidjan to have a question, two questions from Katarina Hohi, who is with Bloomberg. And Katarina says, should the developed nations which acquired vaccines have done more to ensure that low-income countries also acquire vaccines? And then secondly, how much has the vaccine inequality set back Africa, and in particular South Africa, in their attempts to protect their populations?
So could they have done more? Yes. That is the whole spirit of why COVAX was established, as a symbol of global health cooperation, as a symbol of solidarity. And COVAX should be supported. We're also learning from this, the whole exercise, that it is okay to have global centralized mechanisms like COVAX, but it is also in future will be important to have regional facilities like the AVAC, the African Vaccine Acquisition Task Team, so that the two go line in line. The third lesson that that has emerged from this is that we as a continent of 1.2 billion people should come together urgently to begin to discuss ways and means of establishing continental manufacturing capabilities and capacities for vaccines, diagnostics, and drugs, so that we do not mortgage our health security needs to forces that we cannot control. I think that is clear. Let me restate what I mentioned earlier, that we, when countries and individuals are dealing with an unknown threat, like the COVID-19 virus that was threatening the whole world, there's a fear factor. And when there's a fear factor, there's insecurity. And then people tend to, whether you're an individual or a nation, you tend to fold in. And then when the politics are not aligned with appropriate policies and data, then people take the wrong decisions. The wrong decision there is clear, that COVID will not be defeated anywhere in the world except it's defeated everywhere in the world. And Africa is not an exception. It will be a fatal mistake that the developed world sees this as an issue of we would vaccinate our people, and then the people in other parts of the world can take care of their own business. That would be, I hope that is not the thinking, because we all are completely aligned with that except we do this vaccination quickly, okay, except we do this vaccination at scale and meet certain targets, we all struggle as to whether you've been vaccinated in Europe or the United States or anywhere else in the world, the virus will not go away.
Thank you. We have a question from Cara Anna with AP, and she asks, which countries have ordered doses of the Sputnik 5 vaccine?
And I don't know that I can give you the names, but I know that Gabon has, the government of Gabon has signed an approval of that. We know that Guinea had already signed, their regulatory bodies had signed and signed up onto that. You also recall that we as Africa CDC will be looking into their dossiers and will make a statement in the coming days, and that the vaccines, the 300 million doses that they've agreed on, will be made available on the platform. Making those available doesn't mean that we have purchased them. It means that countries can go through the platform and place their orders once we have given a stamp of endorsement to that product there. So I cannot give you very specific details on country by country basis. But watch out in the coming weeks as we stand up our data monitoring surveillance board for vaccines in Africa.
Thank you very much, John. We are going to be overrunning a little bit. The producer has given us an extra 10 minutes, during which we should be mopping up all the remaining questions. So let's move on to Lawrence Caramel with the Le Monde. And Lawrence says, can you give details about the flexibility that is allowed by the WTO regarding intellectual rules on licenses?
So the flexibility that allows is really for IP transfer is I believe it's a win-win for everybody. And it's a win-win that enable us, Africa, to and develop other parts of developing countries to be able to use that technology that has been developed or that has been innovated to be able to manufacture locally, not just for vaccines, but diagnostics and therapeutics. And that will begin to address that inequality gap that we all experience there. I believe it is in no one's interest, and I'll repeat, no one's interest, that we continue to be in this tense situation where it always speaks to the inequality that the world is experiencing in global health. I'll give you two examples. In 2009, the H1N1 virus was declared a pandemic, and vaccines were identified for that virus. And the developing world will only get the vaccines after the pandemic was over. Luckily, the pandemic wasn't as raging as this current pandemic. What happened? Developed world purchased all the vaccines in large amounts. If you actually take the headline news on newspapers at that time in 2009 and you compare it with the headline news in 2021 or 20, you probably think we are in the same year. Okay, I mean, and if you take out the dates, you probably assume that it means. So it is not in nobody's interest to continue to live in a world that speaks to that kind of inequality and that kind of divide. In 1996, the HIV drugs were available, and we saw how mortality in developed world decreased almost drastically. But it would take 10 years before those drugs were accessible in Africa in any meaningful way, 10 years. And it is only after the Global Fund was established and the programs like the US President's Emergency Plan for AIDS Relief, PEPFAR, that we started seeing an upscale introduction of those drugs in Africa. And in between, 12 million Africans died. So, I mean, I just use those numbers to say that any intellectual property transfer it will be beneficial to everybody, because nobody wants to sit back and be proud of that sad event that happened with the 12 million Africans dying in history. We want to be on the right side of history, that we did the right thing as human beings living on the same planet with a common destiny. And this is again an area of interest that the African Union has actually, in their last meetings through the Executive Council and the Bureau of Head of States, expressed a very clear position in support of intellectual IP, intellectual property transfer.
All right, so we have questions coming in from Elisa Fabish, and Elisa says, I work for a German radio station. The question, what do you think of the no-fault compensation program for COVID-19 vaccines? Do you need its help, or could you manage with your own deals with Pfizer, Johnson & Johnson, etc.? What role will it play in the African vaccination process? And then, yes, those are the questions coming from Elisa Fabish, who is working with a German radio station.
No, I mean, we are in this together. I mean, again, we should always have a country-centered approach in this vaccination exercise. When we see whatever is happening in COVAX as part of our strategy, right? That is, our strategy is to vaccinate as a continent at least 60% of our population. And those processes that you just indicated should all be additive to getting us to where we are and are striving to. It's a goal that we will we set upon ourselves. So it's not like us versus what is happening with the COVAX. It is us all together. So we are very supportive of those processes that have been put in place, and we even call for greater partnership that will enhance whatever we are doing with the AVAC mechanism. Again, I know I'm repeating this, we should look at a country-centered approach. That are we helping country X to get to that level of vaccination? Not whether who is doing it, but all of us are doing it to get to that goal.
All right, thank you. We have a question from Paul Adepoju before we move on to our last question for today. And Paul has two questions. He says the Johnson & Johnson vaccine is on track to receive emergency use approval. Considering that it's a single dose and easier to roll out in Africa, what is the plan to introduce it through AVAT? And can it be switched for the AstraZeneca vaccine? Then his other question, he says, what is the plan to simultaneously vaccinate individuals in the DRC and in Guinea against both Ebola and COVID-19?
So, Paul, those are all very good questions. First of all, the Johnson & Johnson, of course, is a single-dose vaccine, is stored at 2 degrees to 4 or 8 degrees. And so that will be, going forward, looks like it's going to play a central role. But let me say this, that as we speak, we should not conceive vaccination programs around one product. It should be a combination of those products. So I give you, and let me expand on that thinking a little bit. First of all, if you give us the Pfizer vaccine that requires -70 refrigerator, I'll be happy to receive it at the airport in Ethiopia or Nairobi and start vaccinations within those capital cities, because we can store them easily. There are -70 degree facilities all over big major cities there, and there are backup generators there. So, but then if I need to move my programs to the remote areas or begin to decentralize it, then that kind of a vaccine becomes probably, you probably will not have -70 degrees there. Then you bring in your AstraZeneca vaccine or other vaccines that require less stringent conditions there. So that by using a combination of vaccines early on, you can begin to achieve your goals. Second is absolutely that the vaccine landscape will continue to improve. We now have a menu of vaccines, and in the coming months, as other vaccine clinical trials are completed, the menu of vaccines will improve, and countries will have a choice or choices of which vaccines to use in their vaccination program. But I don't think that Africa CDC will recommend one specific vaccine to be the dominant vaccine going forward, for all the reasons that you know. We are still learning what this virus can do. We all have seen what it has done with respect to the mutants that can create a knock off some vaccines by a certain level of efficiency. We don't know a lot yet how people that have been vaccinated over 1 year or 2 years will behave in terms of whether they will require a boosting or additional vaccination like the flu. I mean, because of all of that, it will be very risky to just say that we limit our vaccination program around maybe one vaccine, whether it's Johnson & Johnson or AstraZeneca. There's a lot of implementation, science work, or research that would need to go into understanding the post-vaccination scenarios, and that will inform us on building appropriate vaccination programs. In DRC, you talked about Ebola and the COVID vaccination. Of course, the Ebola vaccination is more restricted. In that area where Ebola is ongoing, it is going to be based on a ring vaccination, which means you identify an individual who has been infected, find out map out where their contacts are, then vaccinate all their contacts then. This is very different from vaccination in COVID, where we are out there raising to vaccinate up to about 60% of our population there. So the two processes are not conflicting. They only speak to resources that will show that those vaccinations are carried out at any rate.
Thank you very much, John, for that. I think now it is time for you to give us your main headline points that you want the media to remember coming out of this briefing for today.
So just one headline, at least from my side, is that we, and I mean a collective we, the media, community leaders, civil society, the political leadership should all rally around the vaccination campaigns and make sure that we live with we promote a simple equation that says vaccine plus vaccination equals save lives. Okay, vaccines plus vaccination equals save lives. So if we all rally around that equation, then we'll do our own piece and we'll inform the communities better, let them own this process, and actually convince their neighbor that once vaccines start arriving, as we have seen it now arriving in Senegal, in Ghana and other places, let's go to those vaccination centers and get our vaccines and not be creating or not be propagating rumors that will make it difficult for our continent to be vaccinated. So with that simple formula, anyone can find a place to fit in this struggle. I think history will remember us that the key question that history will ask is, what do we do in this time of crisis? And that we will be all of us. And I think that there's room for all of us to contribute, not just the political leadership or the public health experts or the scientists, but all of us. So otherwise, we get into what I call the valley of death, where vaccines are available, but they cannot get to the other side of vaccination appropriately there. So that is the only message I'll leave you with today.
Thank you very much for all the answering of the questions that you've done during this press briefing. That was Dr. John Nkengasong, who is the director of the Africa Centers for Disease Control and Prevention. I am aware that we've had a follow-up from Dan. So Dan, please, can you write to Neke on the WhatsApp platform, and he will respond to your question about Afreximbank. We were also supposed to come back to a question to Dr. Merawi. I think that we will pose that again next week. And then finally, we had someone who tuned in as anonymous attendee and they had questions, please, anonymous, we cannot take questions from, from anonymous. Kindly for coming briefings, please put your name and the agency that you're representing, and then we'll be able to put your question forward to Dr. John. But otherwise, that's it for today. Thank you all very much for having joined us. Thank you to everybody in the studio, and thank you to Dr. John. We'll meet again next week on Thursday at the same time.
No, thank you all for coming as usual.